The purpose of this award is to identify highly talented junior investigators from low and middle income country institutions who are committed to a career in women, adolescents, and children health research and support their career path to becoming independent researchers. The award provides a $10,000 award to fund a year-long project with added benefits, including access to University of Washington library and data resources, and the opportunity to share work with the global WACh community as we are doing today. Candidates are competitively selected and scored based on their demonstrated commitment to career that includes women, adolescents, and children research, the impact the award may have in catalyzing their research career, and the scientific merit and impact of their proposal. So this year's award was given to Dr. Rafiuk Cosmos Yakubu, and I'll let Kak introduce him a little more.
Thanks, Irene. Yeah, it's a real pleasure today to introduce Dr. Yakubu, who's a senior pediatrician at the Tamale Teaching Hospital in Ghana, and is also a senior lecturer in pediatrics at the University for Development Studies in Tamale as well. When Yakubu applied for the Rising Stars, the reviewers were really struck not only by the high quality of the research and his application, but also the evident passion with which he's pursuing better care for children who have asthma in Ghana, and the extent to which he's really taken that on himself to improve care and research there. He's founded an asthma clinic where he uses spirometry to aid diagnosis, and has instituted evidence-based care involving the use of inhaled steroids as a control of therapy and the development of kind of personalized asthma action plans for each of his patients. In addition to all the kind of innovation he's been taking on in asthma care in Tamale, he's also been a mentor to many junior doctors who have qualified as pediatricians, and was recently granted accreditation to run a pediatric residency program through the university. And I think during the course of his Rising Star, it's been really evident the extent to which Dr. Yakubu has been using the funds and the opportunities provided, not just for his own research, but to kind of bring all of those in his team along with him as well, really extending the benefits of the program to those who he's working with as well, which has been really wonderful to see, and kind of really a model for how we'd like to see the program moving forwards as well. So that's enough of me talking. Let me hand it over to Dr. Yakubu. Thank you.
Thank you very much, Kirk, for that lovely introduction. And as Kirk has introduced, I am a pediatrician specialist at the Tamale Teaching Hospital, and I am currently head of the Pediatric Emergency Unit, and also run a weekly asthma and cardiac clinic where I see children with asthma and also children with various children with various congenital and acquired heart diseases. So this evening, I'm going to be talking to us about my Rising Star project, and I have divided the talk into three. I will first of all talk about my early career training and how certain experiences have influenced my career trajectory, and also how three important studies that I got involved in led me to meet various mentors in my career and who have shaped what I am doing so far. I will then present to you the results of my Rising Star project and also what the future holds for me in my career and also in research. So I attended medical school in the Ashanti region in the Kwame Nkrumah University of Science and Technology that is affiliated to the Konfamochi Teaching Hospital, where I had my clinical training and graduated in 2009. So after graduating, I went to the Tamale Teaching Hospital that is located 500 kilometers away from where I trained. So when I started my house manship rotation, now Being trained as a doctor in Ghana is structured such that after medical school, you undergo an internship or train or working under supervision for 2 years, which we call housemanship. So I did that training at the Tamale Teaching Hospital, and I was struck with the shortages of doctors in the facility, especially doctors at the specialist level. When I started my housemanship training at the Tamale Teaching Hospital, there was just one expatriate pediatrician who came and went to supervise our training. Eventually, he left the hospital and there was no pediatrician in the hospital. In fact, pediatrics was the first rotation that I did. Subsequently, I rotated through obstetrics, gynecology, surgery, and internal medicine. And most of my supervisors and mates thought I would end up in a career in surgery. However, because of the shortages and lack I saw in pediatrics, after I completed my rotations in the other specialties, I went back to pediatrics to support the care of children. During this period, we were joined by one pediatrician, Dr. Anthony Amponsem of blessed memory, and also eventually by one of my mentors who has led me through this journey, Dr. Al-Hassan Abdul Momin, who trained in Turkey and was my previous head of department and now the medical director for the hospital. Now, one experience that struck me a lot and has influenced me during that period of my training was a 6-year-old female who I cared for. She came with a febrile illness with impending respiratory failure that I have diagnosed as epiglottitis. So working with the ENT surgeons at the time, we quickly rushed the patient to the theater where laryngoscopy was done. During the laryngoscopy, a mass was excised. A histopathology showed that the mass was that of pharyngeal cancer. Then I thought to myself, what were the odds that a 6-year-old would have pharyngeal cancer? So we took the biopsy specimen and sent it all the way to the capital of the country, Accra, to the Kolebu Teaching Hospital to be retested. And the results came back the same, pharyngeal cancer. The child was referred to have chemotherapy at the Kolebu Teaching Hospital. The family could not afford it, so remained. He reported again to the hospital with a recurrence and eventually died. This had a profound effect on me and increased my desire to engage in a career and to develop myself in such a way as to improve health of children. So I stayed in the pediatric unit for 2 more years. And eventually, on discussing with Dr. Hassan Abdul Momin and other mentors, I decided to go into a residency program in pediatrics back to my alma mater, Confanochi Teaching Hospital. So I did a pediatric residency under the auspices of the West African College of Physicians and the Ghana College of Physicians and Surgeons. Now, during my residency training, pediatric intensivists had just returned to the Confanochi Teaching Hospital and had started a pediatric intensive care. I fell in love with intensive care and actually was thinking of a career in pediatric intensive care. So I negotiated with our chief resident at the time and also with the head of the intensive care to double the duration of my rotation in the pediatric intensive care so that I could have time to acquire enough skills to be able to offer this critical care to children when I returned to the Tamale Teaching Hospital. I also enjoyed my rotations in pediatric pulmonology and cardiology, where I met mentors like Dr. Blay Ingwa and Dr. Sandra Quatin, who mentored me a lot in this field. So upon my return to Tamale after the first phase of my training, which we call membership, I tried to start a critical care unit where I could ventilate children. However, the challenges were so enormous that I gave up that ambition. and rather started a pulmonology clinic where I attended to patients with asthma, offering follow-up care and care using international protocols. So I started the asthma clinic in collaboration with some pharmaceutical companies. Each patient had a peak flow meter. Those who were not old enough were given spaces to be able to administer their inhaled medications, and we had follow-up clinics for these patients. Hitherto, asthma patients presented to the emergency units with acute exacerbations, but nebulized, they got better. They had bouts of systemic steroids and then were discharged home, only to come back with another asthmatic attack. And I thought that this was not appropriate. And that was why we started the asthma clinic in 2017. Now, in 2018, I left Tamale Teaching Hospital back to the WACh Teaching Hospital for the second phase of my training, which we call here the fellowship training. So after I left in 2018, the asthma clinic collapsed, and I was trained between 2018 and 2020 for my fellowship. Now, it was during my fellowship training that I worked very closely with one of my mentors, Professor Emmanuel Ave NE. Now, as one of the senior residents in the department, I often visited his office to engage in conversations regarding the welfare of other residents in the hospital. During one of these visits, he informed me that he had been asked to write a chapter in the Global Asthma Report 2018 and wanted to work with me to write that chapter, which I gladly accepted and worked closely with him to write that chapter in the 2018 Global Asthma Report. So after writing that report with him, he informed me about an upcoming research project, Acacia, which means achieving control of asthma in children in Africa, which included 6 African countries. Professor Emmanuel Yakubu was the principal investigator for this study. Now, I got to know that before this study, we would be trained in performing spirometry. And I was very glad to get involved in this study because hitherto we had heard about spirometry in the books, we had read about it, but never seen it performed or seen a spirometry report. So I was very eager to participate in this study. Now, prior to that study, my mentor conducted a study which he called the triclosan study, which studied the exposure of children with asthma to a substance, an antiseptic called triclosan that was found in various household agents. We studied the impact of exposure to triclosan on the lung function of asthma children and on control of their asthma. Now, while participating in the triclosan study, I came in contact with an 8-year-old boy, Caleb. Caleb had been referred from Bolgatanga in the Upper East region and had to travel almost 700 kilometers to the WACh Teaching Hospital to obtain care for difficult to control asthma. Caleb was an 8-year-old diagnosed with asthma that had become very difficult to control and was impacting negatively on his schooling and on his growth. So his mother brought him all the way 700 kilometers from Bolgatanga to WACh, where I was then doing my fellowship, and we recruited Caleb for this study. During my conversation with the mother, I got to learn how the family was struggling to ensure that Caleb's asthma was under control. And it was at this time that I promised this widow and her child that after my fellowship training, upon return to the Tamale Teaching Hospital, I was going to start an asthma clinic and they would not have to travel 700 kilometers to obtain care for asthma. So in preparation for the Acacia study, I was trained in spirometry and eventually trained as a trainer in spirometry. So my job in the Acacia study was to help other participants or other clinicians in the study to complete their practical training in spirometry and also supervise the spirometries that they conducted. I also conducted internal validation of the spirometric tests that were done in the Acacia and Kappa studies. So in the Acacia studies, children, adolescents were recruited from schools in Kumasi. Now, children were assessed for symptoms of asthma and the level of control, and then had tests including spirometry and FeNO conducted on them. Now, the purpose of this study was to determine objective evidence of airway obstruction in adolescents who had symptoms of asthma. So first of all, to diagnose asthma in adolescents who hitherto did not have a diagnosis of asthma, because studies have shown that there are many children with symptoms of asthma that remain undiagnosed and therefore untreated. And also for those who already had a diagnosis of asthma, to determine the level of control for these patients. So I participated in these studies, and during the conduct of these studies, one of my mentors, who has been my greatest cheerleaders in this journey, Lindsay Zuba, who is pictured in this slide, informed me that there was an opportunity for training in research called the PATS-MICO. That is the Pan-African Thoracic Society Methods in Epidemiology, Clinical and Operational Research. So I read more about PATS-MICO and then realized I had to travel to South Africa and pay the subsidized fee of $250 to participate. So I told Lindsay I didn't have the money to do that. And so Lindsay worked with the principal investigators of Acacia to sponsor me to attend MICO Level 1 in South Africa. So in South Africa, I was assigned a mentor, Professor Kevin Mortimer, who is pictured with me on this slide. And I worked closely with Kevin to develop a protocol to assess normal lung function values in Ghanaian children. Now, that we have for those who know how lung function tests are conducted to determine normal from abnormal, you know that we usually, after conducting spirometry to determine the forced vital capacity and forced expiratory volume in 1 second, we compare these values to a normal population of children of similar age, similar height, and similar gender. And hitherto, race was an important factor to consider in this comparison. Now, however, in most of the equations that our spirometers come with are inputted with equations that were derived without lung function measurements from African populations. So I determined that I wanted to find normal values for spirometry measurements in Ghanaian children. So after developing this protocol, I applied. There's usually a grant that is given to all levels of MICO trainees to try to implement the protocols that they had developed. So I applied. One, you were granted a $2,500 award to carry out your project. So I applied for this grant. However, I wasn't granted a grant. However, the reply from the reviewers of my protocol were very encouraging. While they saw merit in my protocol, they thought the scope of what I wanted to do was too big for a grant of $2,500 to be able to accomplish. However, I spoke to my mentor, Kevin Mortimer, and then to Professor Emmanuel Adoyibu, who lent me his pyrometer and some resources to get the ethical approval and continue to carry on even without the grant. In 2013, I went for level 2 PATS MUCO. My intention when I attended level 2 PATS MUCO was to develop a protocol to determine lung function of children with sickle cell disease at my clinic at the Tamale Teaching Hospital, and to relate this with the occurrence of acute chest syndrome among these children. However, level 2 PATS MUCO coincided with the annual general scientific meeting of the Respiratory Society of Kenya, and there were many very good presentations. One that stood out was a presentation by Professor Andrew Bush, who highlighted the growing problem of electronic cigarettes in the Western world. So I thought there and then that just like obesity, that used to be a problem only of the West, but is now becoming increasingly a problem in developing world, electronic cigarette use and tobacco use would very soon become a huge problem in Africa and in Ghana for that matter. So I changed my topic to study the impact of the use of tobacco, cigarettes, e-cigarettes on the lung health of adolescents. And I was granted a mentor, Ozgi Yilmaz, and Ozgi helped me to develop the protocol in this inhaled substance study that the Global WACh grant helped me to implement. So pictured here is Ozgi, myself, a mate, and then Richard, who has done a lot of work in smoking, who helped me to develop this project for level 2. So to my project. So my project title was Association of Inhaled Substance Use and Respiratory Problems in Adolescents and Young Adults in the Tamale Metropolis. Now, why did I choose this study? Now, studies have shown that of the 1.3 billion smokers in the world, 80% of these reside in low and middle income countries. And smoking is associated with many deleterious effects, including recurrent respiratory infections, and in the long term, mouth, throat, and lung cancer. Now, why did I think it is important to conduct this research among youth? Now, youth is a very impressionable period of development that bad habits and good habits, once acquired, can remain for the rest of an individual's life. So the aims of my study was to demonstrate increased respiratory symptoms in adolescents who smoked compared to those who do not smoke, and also to demonstrate impaired lung function even in youth among those who smoke compared to those who do not smoke. The intention of this study was also to identify a cohort of adolescent and young adults who smoked, who could then be followed up in the long term in order to test smoking cessation interventions. So the study was a cross-sectional study in which I used respondent-directed sampling to identify adolescents and young adults who smoke. So what I did was to recruit participants from schools and colleges in Tamale, and also their teachers and workers and students rotating through the Tamale Teaching Hospital. So when I approached participants, they had a questionnaire after taking informed consent administered to them. The participants were asked whether they smoked or not. For those who smoked, we then conducted more in-depth counseling and then asked them if they knew other adolescents who smoked. For all participants, demographic data was taken and entered into a case report form, a symptom questionnaire that was modified from the Impala and Bold symptom questionnaire were administered. And for those who smoked, a questionnaire that was modified from the Global Youth Tobacco Survey was also administered. And in this questionnaire, I assessed the extent and the amount of inhaled substance use, and also assess addiction and also the desire to stop smoking. Now, the data was entered into REDCap and subsequently exported to R for statistical analysis. And these are the preliminary data and analysis that I have had so far. So in total, I screened 345 participants. I excluded 9 because they didn't give consent. 3 were excluded because the age was less than the age bracket I was recruiting. 3 had asthma. 1 had previous treatment for TB, while 1 had eye surgery in the past month, and then another had myocardial infarction in the past 1 month. So a total of 336 participants were enrolled, 72 of whom were smokers and 264 non-smokers. So this shows the profile of the enrolled participants. So in terms of gender distribution, 57% of the non-smokers were male, whereas 96%, so overwhelmingly only 3 females were recruited who smoked. 96% of all who were recruited were male, smokers were male. The smokers and non-smokers had similar age distributions. However, in terms of employment status, the non-smokers were more likely to be government employed, whilst those who were smokers were more likely to be self-employed. Non-smokers were also more likely to be students and still in school, while smokers were more likely to have dropped out of school. In terms of educational status, non-smokers were more highly educated than the smokers. Now, in terms of the substances that are smoked, 83% of the smokers were using cigarettes. 52% smoked shisha, or what is called hookah or niagle. And then 15% used electronic cigarettes. Now, at the inception of this study, while developing my protocol, many people thought that electronic cigarette use would not be practiced in Ghana. However, 15% of those smokers that I recruited for this study were using electronic cigarette. And it is only 15% because of the costs. Most youth are not able to afford this. So as our socioeconomic status increases and more youth are able to afford electronic cigarettes, we will have more of them using these electronic cigarettes. There is concern in the Western world concerning the use of electronic cigarettes, because many researchers think the use of electronic cigarettes may be a conduit to introduce the youth to the use of cigarettes that has already been shown to have many negative health effects. The next table shows a comparison of the lung function measurements of smokers against non-smokers. So this compares the forced vital capacity and the forced expiratory volume in 1 second among smokers and non-smokers. Now, the forced vital capacity is the total volume of air that an individual is able to breathe in and then blow out forcefully during the spirometry maneuver. Whilst the forced expiratory volume in the first second is the volume of air that comes out in the first second of the spirometry maneuver. So while the forced vital capacity can tell us if there is injury to the lung parenchyma and therefore reduce lung volumes, the forced expiratory volume in the first second is an indicator of the patency, or it is a marker of obstruction of the airways. So I compared these two parameters in the two groups, and we can see that the adjusted p-value. So we see on average, smokers a forced vital capacity that was 100 mils less than non-smokers. And they had a forced expiratory volume in the first second that was 110 mils less than that of non-smokers. Now, while these values did not reach statistical significance, it is important to note whether it reaches clinical significance. And just as an analogy, for any human being whose lung capacity has reached maximum between the ages of 19 and 25, the lung function or the lung volumes begin to decline every year. The yearly decline in forced expiratory volume in the first second is about 30 mils every year, while the yearly decline in forced vital capacity is about 70 mils every year. Now, what does this tell us about the values that I am presenting? If smokers have a forced expiratory volume in 1 second, that is on average 110 mils less than that of non-smokers, then it implies that at the point of measuring these values, smokers had already, through the habit of smoking, lost 3 years of their forced expiratory volume in the first second. Now, the next table shows a comparison of the Z-scores of the forced vital capacity and forced expiratory volume in the first second. And this shows some interesting statistics. While the average Z-score for smokers was higher than that of non-smokers, the forced expiratory volume was less than that of non-smoking. And that implies that the habit of smoking led probably to more obstruction in the airway for smokers. Now, comparing symptoms among smokers and non-smokers, it was found that smokers were more likely to have respiratory symptoms than non-smokers. Smokers were more likely to have multiple respiratory symptoms than non-smokers, and almost no non-smoker had chest pain, while many smokers had chest pain. And smokers had higher dyspnea scores than non-smokers. The addictions assessment is still being analyzed. Now, when I assess the desire to stop smoking among the smokers, 79% of them had the desire to stop smoking. 52% made it known that in the next 12 months they intended to stop smoking. 93% thought that at any point in time that they wanted to stop smoking, they could stop smoking. But this is very debatable. Some wanted 21% thought in the next month they will stop smoking, 19% in the next year, and 48%, almost half of the participants wanted to stop smoking, but they had not made up their mind when they would quit smoking. And 4.5% were not interested in stopping the habit of smoking at all. Now, interestingly, only 13% of the smokers had ever had counseling from a health worker to stop the habit of smoking. And 3 of these out of the 9 were participants who had developed symptoms of chronic obstructive pulmonary disease before they got the advice to stop smoking. It is important as clinicians to give this advice before symptoms of disease ensue. So in conclusion, smokers had more respiratory symptoms than non-smokers. Smokers had lower lung function parameters than non-smokers, and many current smokers have the desire to stop smoking. And very few adolescents and young adults who have this desire to stop smoking ever received any counseling or medical treatment to help them to stop the habit of smoking. So what does the future hold for me? I intend to carry out qualitative study to have an in-depth understanding of factors associated with inhaled substance use and explore potential interventions to mitigate this. And this was suggested to me by Donna, who went through my proposal extensively and advised that this will be a potential area to explore. I will also be looking at the knowledge, attitude, and practice among clinicians regarding counseling on smoking cessation, and also follow up those that I have recruited longitudinally to see the impact on their lung function, and also to explore smoking cessation intervention. It is my overarching aim to mentor young doctors to be able to win grants for research that will improve maternal and child health and to become a faculty of FWACP. So hopefully in September, if I'm able to raise the funds for my air ticket to Kenya and pay the subsidized fee, I will be attending MGCP level 3, where I will be presenting the findings of this study and also upon completion, work proving my research knowledge so I can become a faculty of MGCP to be able to mentor younger researchers. So what have I achieved so far? Through the help of Lindsay, and because of this study, 6 members of my team have been trained in foundational spirometry and are able to offer this service so far as consumables are available. These are members of my team. This was me in MGCP level 2. That is Sandra Quatten, a consultant pulmonologist, pediatric pulmonologist at the FWACH Teaching Hospital, who we consult when we have difficult to treat asthma. That is Professor Rafiuk, the current president of the Pan-African Thoracic Society, whose doors are always open to us when we have research problems. This is Diane. She is currently in training as a pulmonologist and has been working closely with her. We have Gabby and then Spade, who are both pediatricians who I work with closely. So recently at the annual general scientific meeting of the pediatric conference, 2 of my mentees presented abstracts, one of which won the second best poster presentation. So this is at the annual general scientific meeting. This was my presentation at MGCP level 2. We have chalked some successes and we hope to continue to work to improve child health in Tamale. So pictured with me here is Lindsay, who has been my biggest cheerleader in all of this. That's Richard, who has done a lot of work on smoking and who I work with closely. I can't bring this meeting to a close without mentioning the support of my mentor at the FWACH Teaching Hospital, Dr. Blair Ingwa, who held my hands, took me through my fellowship training, helping me with my dissertation. And also Professor Al-Hassan Abdul-Momin, who was the first person to introduce me to the WACh Award and also has mentored me through the process of this study. To the WACh team who have guided me over the past year, Kirk, Irene, and Stephanie, who ensured that I met my timelines, I am very grateful. And Donna gave me very important advice in implementing my study. I am very grateful. And Marie, who did the statistical analysis for me, I am very, very grateful. Thank you all, my audience, both from Ghana, Turkey, and the WACh team for listening to me.
Thank you so much, Dr. Yakubu. You're getting a lot of applause, and I hope that you have the opportunity to read the chat at some point, because there's a lot of praise for the spirit that you've taken this on with and the work that you've done. It's really fantastic. We are lucky. We've got quite a bit of time for some questions, so really gonna have a good discussion, I hope. So if you have a question, just raise your hand in the chat, and I will try to call people out, or feel free to jump in if you like. Yeah, are there any questions?
Yeah, I can go first. I think Dr. Yakubu, this is very, very impressive. I was especially struck with how you were able to present the results in a very clinically relevant way and interpret those numbers, to directly apply it to clinical work. I mean, that was really done well. So my question to you is, because these are young people, and I think, smoking can be a habit that people acquire early and it's very hard to break. What kind of smoking prevention programs are available in your setting, or are you thinking of that as one of the directions that you could take to support youth to, not even get into smoking in the first place?
Yes, thank you very much, Irene, for that question. And that is very important because there is currently no smoking cessation program where I work, and actually no smoking cessation program in the rest of the country, except for those that get into mental health institutions as a result of the use of these substances. And it is important that we have programs to help the youth stop smoking even before they suffer any mental health problems. Now, one study that I was involved in that looked at the availability of medication for chronic respiratory condition and smoking cessation, like nicotine replacement therapy, showed that in the entire Tamale, there was none. And so any clinician that wanted to help an individual stop smoking had no nicotine replacement therapy, had nothing to follow. And this is one of the directions I would like to take to develop some of these interventions to help individuals to stop smoking.
Fantastic. Donna, I see you've got a question. Do you want to jump in?
Yeah, that was a fantastic presentation. You are so inspiring. Your dedication to the children and youth of Ghana is incredibly inspiring. Thank you so much for sharing your story and your work on this project. I was wondering if it was difficult to identify smokers for your study, like were the youth reluctant to admit their smoking status? And can you talk a little bit about how smoking is seen socially in northern Ghana? And like, is it socially acceptable? Is it stigmatized? Are there reasons to hide this status? And also, is there a lot of marketing of products to youth in Ghana?
So yes, thank you very much for the question. Yes, smoking is stigmatized in Ghana, and so you don't see much of open smoking in Ghana. Now, when I was recruiting the participants who smoked, it was quite difficult because in addition to smoking cigarettes, some of these youth were using other substances that were illicit, such as marijuana. So when I started to approach them to recruit them for this study, they were initially reluctant to participate in the study. Now, some of them thought that I was coming to tell them to stop smoking. So one of the participants that I approached, that was a referral from an individual, I said, oh, we know smoking is bad. We know it is bad, but we are still using it. So if you are coming to advise us to stop smoking, forget it. So I had to explain to them that that was not my purpose and explain the study to them and say, even though I had the desire to encourage them to stop smoking, I would like to work with them so that as and when they wanted to stop the habit, they will stop smoking. So yes, it is stigmatized, and many of the youth that smoke also use other substances that are stigmatized, and it was difficult to get these youth. But once I was able to gain their trust and also had a chance, gave them the chance to ask questions about some of the symptoms that they had and gave them free medical advice, they now became open to talk to me about their smoking habits. So that was how the recruitment went. And it is the reason why I use the respondent-directed survey, because they are a group that are difficult to reach.
Oh, that's really amazing. It just goes to show the complexities of doing research and your ability to use your, social skills to engage with the participants. Is there much marketing of products in Ghana?
Not in the mainstream media. So we don't have a lot of marketing of these products in the mainstream media. So even when I asked about electronic cigarettes, and I was surprised to realize that some of them were using electronic cigarettes, they had specific suppliers that only people within their circle knew. So it is actually marketed within this circle of individuals, but there's no mainstream marketing of tobacco products for instance, on the television and on other media, radio, etc. There's no marketing of tobacco, but the marketing goes on within this space. I actually wanted to see where they bought the electronic cigarettes, but wasn't able to get the supplier.
Thank you. That was really fantastic.
I'm just going to pull a question out of the chat because I think it's a really interesting one. So this was being asked by Betty, who said that it would be interesting to know more about the changing climatic conditions and how they may affect respiratory disorders among children in Ghana. I wonder, Dr. Yakubu, if you have any thoughts about, how the climate is changing and any predictions on how that might alter respiratory disease among children and teenagers there.
Yes, so last year during World Lung Day, I actually, together with a team of other clinicians, embarked on a campaign to educate the public about the impact of air pollution on respiratory ailments. Now, it is known by the WHO that more than 90% of the world individuals are exposed to levels of particulate matter 2.5, what they would typically call PM 2.5, at harmful levels than the WHO levels. And these predispose the respiratory system to infections. So air pollution, first of all, it can predispose to pneumonia and other lung infections. Air pollution is also a trigger for acute exacerbations of asthma. And one of the demonstrations of this was about 3 years ago. After a thunderstorm, we had a large number of individuals reporting to Kumasi, hospitals in Kumasi, with acute asthma exacerbation in what was called the thunderstorm asthma. So air pollution could predispose to lung ailments, including pneumonia. It's also a precursor of asthmatic attacks. And yes, we need to look at the air pollution levels and take measures to mitigate these. It's one of the areas I would want to look into in the future.
Fantastic, thank you. I wonder if there are any more questions. Please jump in now.
Hello, Betty Bando here. You just asked my question for me, but I thank you very much for that. I want to say a big thank you to Cosmos for a very insightful presentation. I have a young daughter who, anytime there's a change in the weather, her asthma exacerbates. So the question I asked, really, it's personal to me because I have a child with experiences along those lines. But what I want to find out is, Cosmos, are you actually, apart from the training you are giving to maybe doctors in Tamale very close to you, are you also looking at training other people who may not be within your very close vicinity, other doctors? Because sometimes it's terribly difficult for them to, at least in my case, to diagnose, very young children of respiratory disease such as asthma. Because they will tell you that the child is too young, it's just a respiratory disorder. We can't say it's asthma until she's done the spirometry, and they give you all sort of terms. Okay, so for mothers or for people with children who have such conditions, what are you doing? Are you training other doctors, other health professionals who really may be our first point of contact. You know, the specialist, we have to be referred to you, but for those who are our first point of contact, the physician assistants, the other medical doctors, are you giving them that kind of training so that I am assured that when I take my child to the hospital, the child will not be misdiagnosed for something else? You know, thank you very much.
Betty, thank you very much for that question. So yes, we are taking steps to educate both clinicians and the public on not just asthma, but other respiratory conditions. So last year, together with a family physician colleague of mine, we started an NGO. So we started it, it was called the the Northern Asthma Action Brigade. And this was to educate clinicians and the public on asthma, recognizing the symptoms of asthma and also managing asthma, especially in children. We eventually changed the name to Lung Health Ghana. Lung Health Ghana. So we have registered this entity, and yearly, during World Asthma Day, World Lung Day, World Pneumonia Day, we engage in education activities. We organize workshops, we visit schools, and also educate our members who are health personnel how to recognize these respiratory ailments and manage them. It is our aim to collaborate with other organizations like the Ghana Thoracic Society and others to make sure we can educate a wider audience to ensure that we have a growing group of clinicians that can recognize pneumonia, can recognize asthma, even in children, diagnose it and treat it. So that is what we have done so far, and we hope to continue to improve on what we are doing.
Thank you very much. Lastly, Cosmos, I am an immunologist by training, so should you need an immunologist, you can actually sit and then put some thoughts together and do collaborative research, because I'm serious, I'm really, really interested in this climatic change and its impact on respiratory illness, because there is evidence that there is some impact, but not much work has been done in Ghana, and it would be good to actually go look into it and then present some good data on it. So thank you very much.
I'll get in touch.
Thank you.
And sorry for stealing your question, Dr. Bando. Irene, I can see you have a question in the chat. Would you mind reading it out?
Yeah, sure. Sorry, Dr. Yakubu. Sorry.
Yes.
Just a quick one about management of asthma in children and some of the baby innovations, particularly because spacers inhaled medication is quite expensive. How have you gone around that?
Take the question again.
About management of asthma in children in your setting, especially because we know that the cost of spacers and inhaled medicine is quite expensive.
Yes. So yes, especially the use of spacers in young children, the spacers are expensive. Fortunately, I got in touch with a group. It's an asthma advocacy group led by a pharmacist called Fifi. I was hoping that he will be in this presentation. If you are here, Fifi, you can give us a hand. So he worked with an organization that got spacers free of charge. So for young children that need these spacers, they are able to get it in my clinic free of charge. Now, for the inhaled steroids, that one, we are working to get it on the health insurance. Not many of them are on the health insurance now, but there is one combined steroid long-acting beta agonist, the one by AstraZeneca, Symbicort, that has been gotten onto the national health insurance at a very subsidized price. So for children who are 7, 8 years and above, who can use this Tebihaler, it is under the national health insurance, and they are able to get it with their health insurance cards. Stacey we have gotten free of charge, and we are hoping that the other inhaled medications, through advocacy, as the government hears our voices, they will add these on to our National Health Insurance list of medication.
Fantastic. We've got 2 minutes left, so there may be time for one more quick question if anyone wants to jump in. Donna, please.
Are the inhaled steroids on the WHO essential medicine list?
Yes, they are on the essential medicine list, but not all of the medications on the essential medicine list are on our National Health Insurance list of medications. They are being gotten onto the list one after the other. The one that has gotten onto the National Health Insurance Scheme list of drugs covered is what I mentioned, Symbicort by AstraZeneca. So as we advocate, the medicines are gotten on one after the other.
Thank you.
Fantastic. Let's close there. I'm sure if there are lingering questions or connections, hopefully Dr. Yakubu is okay if you reach out. And if you need to contact details, feel free to message me or Irene or Stephanie, and we can try to link you. But thank you so much, Dr. Yakubu. It's been wonderful working with you over the last year, 18 months. And yeah, looking forward to continuing as we move forwards. Yeah, thank you. Bye.
Thank you so much for all the support. And thank you to all my colleagues from Ghana. Thank you, Osgi, for joining. I'm very grateful that you made the time to join us.
Thank you, Dr. Yakubu. Wonderful presentation. It was also an honor to be able to support you throughout this award journey.
Thank you.
Thank you.
Thanks, everyone.
Bye.
Bye.
Bye-bye, everyone. Well done, Cosmos.
Thank you, Osgi. Bye.